back. I am your host, Jason Miles, and this is Revolution Podcast. I'm back from my, I don't even want to say vacation. I'm just back. Don't know how you guys feel about that. Maybe some people wish I was gone longer. But I'm trying to go up more often to see my family. And it's very hard doing this show. Because as the show is getting more successful, we're adding more, we're doing more. Love it. Hell in a personal life. But I did get to see my child. That was wonderful. To watch movies. Go hang out in Berkeley with the little one. And the big one. Good times. This show is a show that he's pretty much part of the TIR crew. He's the sometimes Y member of the TIR crew. Ray Reed helped put this show together. He's helped put a lot of shows together for what we do. And he suggested over a month ago that we have Dean Robinson on. Pascal had known of Dean's work because Dean did write a great book about black nationalism. But Dean is a social epidemiologist. So in this episode, we talk about racecraft in healthcare statistics. Sorry, I can't speak. Statistics. And implicit bias in medicine. And why the answer to these problems that are very, 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 very well researched, there's a lot of research about it, is socialized medicine, or Medicare for all, single payer. And then in the bonus after hours champagne room, I definitely wanted to ask Dean more about the Black Nationalism book that he wrote. And Pascal definitely had more questions for that. And it got raw. I mean, there's something about knowing you're behind a paywall that lowers inhibitions. Hence the name, the champagne room. It's like when people have that drink and they're like, oh, I feel better. I feel more confident. So if you want to hear that, there's only one way, and that is become a patron. Patreon.com/Bitter Lake Presents. And if you want to watch these shows live, Tuesday through Thursday, 6 p.m. Pacific Time, Saturday, 9 a.m. Pacific Time, YouTube.com/This Is Revolution Podcast. Don't forget we're on Twitch, twitch.tv/This Is Revolution Oakland. You can watch it live. It's more fun live. You get to participate in the conversation. Thank you guys very much. Racecraft in healthcare with Dr. Dean Robinson, and I am out. Good evening, everyone, and welcome to another episode of This is Revolution Podcast. I am your host, Jason Miles, and if you are new to the program, please hit the like, please hit the subscribe, and don't forget to hit that bell as we are constantly adding new programming to the channel all the time. Speaking of such, tomorrow night we'll be doing a video essay and a recap show at our normal time at 6 p.m. So definitely hit the bell, stay notified whenever we go live. And before bringing in my co-host, I want to congratulate my Denver Broncos on pulling off one of the largest trades of the year so far to get Russell Wilson, hopefully lead us to the Super Bowl. And on that note, let me bring in my homie, my dog. He is the man of the Mau Mau Hour. He is the Pascal Robert.
Peace and greetings to the chat. Peace and greetings to the audience. Peace and greetings, Jason Miles.
Someone says I look like a gay lumberjack. I look like a hot gay lumberjack. So add that in there. Not just your standard gay lumberjack. Hot.
I'm just glad you're embracing your inner stuff.
I mean, I look like a fucking hot lumberjack that just bypasses any sort of sexual preference.
Someone said, "Where's my neck?" It's here somewhere.
How are you today?
Doing all right. I told you I was doing some reading of Cedric Johnson's book, which is very good. The Panthers Can't Save Us Now. And for some very bizarre reason, right before the show, as I was eating my normal diet of fruit salad and maybe sometimes a tuna sandwich, I watched an episode of the new Fresh Prince of Bel-Air, and I was pretty much traumatized. I didn't like it. It was very depressing.
As the great inner city philosophers, Souls of Mischief, once said, that's when you lost.
You know what's so funny you brought up the Souls of Mischief? Their famous song, 93 Till Infinity, came through my timeline today, and I felt like posting it. And I was like, damn, that was a dope-ass cut, man.
Great song, great video, makes you want to go hiking for no reason. Love it. Love it. Yeah, someone says the grim, dark Fresh Prince. I don't know why they wanted to make the Fresh Prince darker.
Yo, let me tell you, that show is so depressing, the first episode.
Is Philadelphia really like true to form?
Let me tell you, I haven't been to Philly in over 25 years, but I can tell you that when I was in Philly in the 90s, late 80s, Philly is kind of grimy. I used to date a woman who used to hang out in Philly. She used to call it Philadelphia.
Yeah, you know who else used to call it that? Rush Limbaugh.
And I didn't appreciate that because there are a lot of interesting cultural phenomena that come out of Philadelphia. The Philadelphia sound, one of my favorite forms of black soul music.
Teddy Pendergrass comes out of Philadelphia.
Teddy Pendergrass, the OJs, Gamble and Huff, a lot of black Muslims. Philly is like black Muslim sense, like the Mecca of black Muslims in America.
Philly has a black punk scene as well.
As a matter of fact, you know that the contemporary trend of black men growing long beards starts in Philadelphia in the Muslim community. That's why they call it the Philly beard.
I did not know that. I never called it the Philly beard. You know what else Philadelphia has? White boy soul.
White boy soul, yes, white boy soul.
White boy soul is definitely, you can have a white boy soul off and see if Philly can be. Where's Michael McDonald from?
I think he's a West Coast. He's Doobie Brothers, so that'd be West Coast.
But he came in after the fact. He was with they did Asia. What's it called? I can't think of their name right now.
By the way, also been listening to some Doobie Brothers.
Yeah.
Some righteous music.
Yeah.
You call it yacht rock, and I don't want to go there.
Hey, it's okay. It's okay. We don't have guilty pleasures here. We just have pleasures.
So let's get to our guest because he's probably bored and really upset already.
Kevin Hart and Dr. Umar from Philly. Yes. And
yes, that's correct.
Philly? Daryl Hall. And is Daryl Hall the king of white boy soul? No. Maybe.
Mark Lamont Hill is also from Philly.
Sure. But is he better
As
than
is Bill Cosby?
So let's.
Oh, that was
Is this racism? Or is this racism in society and in healthcare, or is?
Racism is a significant contributor, I think, to it in multiple ways. Some ways in which the racism is obvious to individuals, and many ways in which the racism is not obvious to individuals. So let me give a couple examples. Back in around 2000, I was invited by the Institute of Medicine to serve on a committee that was going to address the question, what happens when blacks...
no audio.
I muted myself because everybody goes, it's a slapback.
I was wondering, did you want to do that on purpose?
No.
I did
not. Let's bring in our guest. Dean Robinson is an associate professor of political science at the University of Massachusetts Amherst. He holds a PhD from Yale University in political science and did postdoctoral training in social epidemiology at the Harvard T.H. Chan School of Public Health. Robinson's interests range between Black politics and social thought and the political and policy dimensions of racial and class inequities in health in the United States. Please welcome, coming all the way live from Massachusetts, Dean Robinson.
Hello, hello.
Dean Robinson, first of all, I got to big you up and give you your full and total props. For those who don't know, I've known Dean Robinson for a few years. We've talked a couple of times on the phone. For those who are not familiar with Dean's work, Dean Robinson has a very good book on Black nationalism. What is the full title of your book, Dean? I read it. I forgot the full title.
Black Nationalism in American Politics and Thought. But I'm working on a second edition.
That's correct. For those who do not know, Dean Robinson is one of the more silent and clandestine students of Adolph Reed, he is definitely within the Reed tradition in terms of Black political analysis and Black political thought. Dean is very sharp in his thought and analysis of all things Black politics. And Dean is also from Dominica. I got to shout out my Caribbean brother. He's a fellow island man, and the brothers and sisters of Dominica also understand Haitian Creole. I'm not going to speak any with Dean right now, but I have always had great admiration and affection for this brother as a scholar and intellectual, and his work has been very, very influential, particularly his book on Black nationalism. So I would like y'all to give a round of applause for Professor Dean Robinson. There you go. So, Dean, I hope things are going well for you in Massachusetts.
Going okay. Going all right up in Massachusetts.
So, Dean, we invited you on our show today because you had told me a couple of years ago that you had been very fortunate enough to get some research funding, some grant funding, to do scholarship about race medical statistics, medical data, and healthcare. And that, I was very excited about your fellowship. And the subject of our show tonight, as we've entitled Racecraft and Medical Statistics. Now, some of our audience may not be familiar with Barbara and Karen Field's book Racecraft, which I have here in my stacks, but I'm not going to reach out to. But as I know you are familiar, because the Field sisters are definitely within the Reed tradition. Can you explain for our audience what exactly do we mean? Because I know what we mean when we say racecraft in medical statistics. What exactly is that suggesting or intimating?
Yeah, it's suggesting this. So, I think the idea behind racecraft, like the idea behind witchcraft, is not to say that the phenomenon's not real, but it is kind of collectively imagined, right? It's collectively imagined in a way that it can have an impact on reality, even though it's not really capturing anything in the way of a meaningful distinction. So I think a problem with the way that data is reported in terms of racial, ethnic, or let's say indigenous status is if you don't properly contextualize what you set out to reveal in the data, it can lead to very unfortunate and problematic interpretations of the data that you're viewing that might suggest that, say, in the area of health disparities or health inequalities, instead of seeing the disparity or the inequality as the result of social, economic, political processes, they get interpreted as the result of attributes, genetic, biologically determined attributes of the population in question. And I think that that's a major problem in the way health statistics around race, ethnicity, and these sorts of categories. That's a problem with that you see today, where there's not enough context behind the data that we're looking at, and that has the tendency of reproducing the idea that what we call race or what we call ethnicity are real, meaningful kind of genetic distinctions among populations.
So Dean, can I trouble you to possibly give our audience an example of what you would call racecraft in terms of medical statistical analysis? Is that something that you'd be willing to do for us?
Well, I mean, I could hazard that by saying that over the course of the pandemic, it was well documented, it was well discussed that racial and ethnic, populations had a much higher mortality, than the general population. If you look at death rates, if you look at, risk based on pre-existing conditions, we heard a lot about that. But when you merely recite those statistics, it can lead to the interpretation that, well, maybe there's something about those populations, something in their kind of genetic predisposition that might increase risk of illness and death, rather than understanding any kind of health outcome as the result of economic and political processes. And that's the point that I'd really emphasize, that in the end, the health outcomes really of any racial, ethnic, indigenous category, including whites in America, these statistics are reflections of political economy. They're reflections of political and economic processes and inequality, not some inherent, again, discrete, genetic differences, among the populations that we look at.
So you mean to tell me that when we hear things like 35% of black children or black men within the category of living in X area are 65% more likely to have diabetes than white men who are 35% of this category who live in this area. There's a problem with framing those statistics in that way without greater context.
Yeah, absolutely. I mean, I think that the audience is familiar with this idea of intersectional analysis, right? That you're supposed to, look at multiple factors in explaining an outcome. And, if we take intersectional theory with any degree of seriousness, you'd want to factor in class or, position in a capitalistic economic hierarchy as one of the fundamental determinants, as well as, other ascriptive categories like race, ethnicity, indigenous status. So to say that more simply, class is the most powerful predictor of illness and death, morbidity and mortality. So that, among blacks in the United States, you see a class gradient where, the poor have higher death rates than the middle class. Middle class has higher death rates than the affluent, and that's just among black people in the United States. So there's what we call a class gradient within each population, and then you'd look at disadvantages that are compounded by institutional racism and that sort of thing. But unfortunately, I'd say that when you simply report about elevated rates of diabetes among black people or various populations, indigenous, and you don't contextualize that within social status as a function of class, you're really missing a very important dimension of the way disease and death is distributed, within a population.
What about the argument that there is so much implicit bias within the healthcare world that it kind of permeates even the class discussion? Part of that clip that I was trying to play showed that there was quite a bit of research done that regardless of where you were in class, you still were going to have a harder time with going to the doctor.
Yeah. So there is evidence of implicit bias even when you control for things like the type of insurance you have, your age, your sex, the conditions that you present with. There is evidence, right, of unequal treatment in the clinical setting. There's no question about that. But it's important to note that, that is not inevitable, that basically equitable access to appropriate care has often been shown to, eliminate those disparities that you see. So for example, we know that that Black men in the United States have the highest prostate cancer mortality, among all populations. But we also know that in the right healthcare system, right, systems that are less fragmented and less commodified, where quality of care is emphasized, you don't really see the manifestation of that kind of racial disparity.
So like the VA.
Yeah. So there is evidence of implicit bias. I think it's exacerbated in a very fragmented, more commodified kind of healthcare system. But there's also ways that we could address that, and that's one of the reasons that we need to get behind the idea of an improved Medicare for all, because that's one of the ways that you provide not only a kind of universal basis of funding, but that funding then becomes a mechanism through which you can enforce compliance and make sure that whether it's gender, whether it's race, whether it's indigenous status, that patients are receiving, appropriate and quality care in that clinical encounter.
So you're seeing it more as healthcare being a commodity kind of forces a eugenic thought in the price breakdown and
Yeah, well, I
treatment
guess
and,
I'd
and
say
quality of care.
this, that, I'd say it this way, that you kind of mobilize stereotype under certain conditions. And, we all know that, what the practice of medicine is like right now. You often don't have consistency in terms of your primary care. The examinations tend to be rushed. Insurance companies mediate. It's a very fragmented system, very high pressure system. And under those conditions, that's when people tend to mobilize these kind of stereotypes and implicit biases, to where, there was a study in the Journal of the American Medical Association Pediatrics, I think it was 2015, that showed that, children presenting in emergency room settings, all things being equal, Black children were less likely to be prescribed pain meds, even though they're presenting for appendicitis, right? So again, under certain types of clinical encounters, it's plausible, right, that these stereotypes and these biases can be there. And by contrast, when, given the right system, given the right approach to quality of care, you don't find that those disparities are, materialize in quite the same way.
Do we have actual studies to demonstrate that certain healthcare disparities that exist, particularly with Black men, because they'd be the ones more likely in these facilities, who receive healthcare through the VA system, as opposed to, say, Black men who receive healthcare through Medicaid, Medicare, or maybe private care, how in the case of a kind of government system like the VA, those disparities shrink significantly, while those same type of health phenomenon, depending on the type of medical care insurance the person has, racial disparities proliferate. Do we have studies to that effect?
Yeah, and I have to say that my area is more social epidemiology, so I'm not really focusing as much as health services research. But the answer is yes. There is evidence that the system like the VA, which is the closest thing we have in the United States to a socialized medicine. The health care workers in that system are government employees. The facilities are government owned. Part of the reason that the VA can target these kind of disparities more is because their surveillance is different, because everyone's in a uniform system. They capture uniform data that allows them to look at, well, if patients are presenting with the identical symptoms, similar medical conditions, similar age, and so forth, is there disparate treatment, right? So that's part of the reason why you see that kind of effect in a system like the VA. It starts with the fact that you have a different type of surveillance, which is another argument for an improved Medicare for all, right? For putting everyone in a standardized public system. It provides a platform through which we can identify patterns of disparate treatment and then, ensure that those not occur.
Wow, this is really, really fascinating. We're kind of getting to the crux of the matter. So, can you demonstrate for our audience how using racial categories for healthcare statistics that are driven by class and quality of life harkens back to a type of scientific racism or eugenics? Do you think you could elaborate on how that may bring forth those results?
Yeah, well, I kind of think I kind of spoke to it already in terms of patterns of COVID disease and death rates of COVID, morbidity and mortality. When you just recite, statistics about disparate impact, higher elevated mortality, say among, Blacks in the United States, among Puerto Ricans, among, Native populations, you miss the fact, as I said before, that class is really fundamental. I mean, consider this, the essentially the white working class in the United States, a number of recent studies have shown, have seen their health statistics stagnate. There's some evidence that white women without a high school degree have seen their life expectancy reversed, right? So I guess the point I'd make is that the way you know that the emphasis on race and kind of essential notions of race as biology are flawed is not only to look at, as I said before, differences by class among, say, Black people or Native Americans, Indigenous people, Latino populations. You see class differences, health differences within those populations, but it's also to take up the sort of worsening health statistics of many whites in the United States, especially compared to their counterparts in other wealthy nations, right? Like we would never imagine that the declining, the increasing health disadvantage of working class whites in the United States is attributable to any essential biological difference, right? We wouldn't say that. But of course, when you invoke, racial and ethnic categories, there can be a tendency to kind of reduce, again, the disparity and the inequity that you see to beliefs about essential differences that harken back to, things like genetics or, the kind of biological determinism, that has existed, across U.S. history. So.
Well, and what's interesting is that if we were to continue in that formulation of relegating health disparities and outcomes to race and ethnicity without a more multifaceted class analysis, then one of the logical consequences of that is that those who finance healthcare systems can say that because we know it's genetic, because they're Black, we don't have to really create a remedy because it's biological, it's health, it's just the nature of the way it is. But if you actually understand that these phenomenon are based on the quality of life, political economy, and class of these Black and brown people, it creates an incentive or a necessity to address the material conditions of their lives that actually correlate to these health outcomes. Would that not be a correct way in explaining how relegating this to simply race almost renders remedy to the system futile in some ways?
No, absolutely. I mean, it's deeply flawed. I mean, part of the problem of just sort of highlighting racial disparities, as I said, is it can lead to problematic interpretations in the clinical encounter. It can lead to problematic interpretations about, what you're seeing when, to your point, what you're really seeing is adverse exposure of a material nature and a psychological nature. And this is what I mean by that. So in social epidemiology, when scholars have explained this graded pattern, this class or socioeconomic pattern to illness and disease, they land on two explanations: that as you go down the class ladder, individuals face a different set of material exposure and a different type of psychosocial exposure. So, the material exposure, it's housing, it's where you work, it's what you breathe, it's what you eat, right? It's cumulative material injury. That's one of the ways that that health disparities become manifest. But then there's also evidence for a kind of psychosocial dimension. There's evidence that the feeling of inferiority or feeling of subordination, feeling that you lack control, also exerts pressure on the human immune function through the stress response, right? So the stress response can be manifested through kind of material things that you're facing, grueling labor, and that sort of thing. But there's also a psychosocial dimension, right? It is literally the experience of subordination can also make you sick. So that is why, as you go from high to low, we would say that both types of exposure increase. The material source of injuries that not just poor people, working class, you have to be pretty high up in the social structure to escape a lot of these things. So there's a kind of adverse material exposure. But then there really is evidence that your subjective experience of inferiority, of subordination, also makes you sick through a kind of stress response, right? And when we focus on race and ethnicity in that kind of simplistic way, you get away from those deeper, what they call social determinants, right? All of which reflect political economic power, right? You get away from that, and as you say, you reduce it to a genetic explanation, or if not a genetic explanation, maybe a behavioral explanation. Maybe it's something that group is not doing. Yeah, so it really does sort of obfuscate the deeper sources of health inequality, in the United States and elsewhere.
We had a super chat that I wanted to bring up. I actually do remember the question. There it is, by Bryce Adams. Thank you very much, Bryce, for your generous super chat. Question for Dean Robinson: how have Black listeners or people you have engaged with reacted to your analysis regarding racecraft in medical statistics?
Well, I mean, it depends on the audience. I do work with a group in Springfield, mostly low-income Black men, middle-aged, MOCA, men of color health awareness in Springfield, Massachusetts. And I participate. I'm sort of part of their health promotion curriculum, and I discuss these kind of things. For those men, and not a lot of formal education, poor working class, mostly Black, some Latino men in Springfield. The point is pretty obvious. They know that the source of their disadvantage is rooted in economics and poverty and in implication in criminal justice, lack of unionized jobs. I think they have a strikingly clear analysis. I think that sometimes it may be among more academic audiences that it's sometimes maybe harder to connect some of these dots. But I think I think that's an excellent point. I'll also say that there's probably more attention to this in sort of medical school education. There was a paper that came out, can't remember when, it's within the last 2 years since the pandemic, where some researchers in, I think it was the New England Journal of Medicine, raised the fact, rely on these kind of algorithms of treatment, right? So again, you have patients that are presenting for the very same medical concern, and they're in medicine today, they're still deploying these algorithms that lead the clinician to weigh or factor or consider what they're seeing in a different light. That's really rooted in these old, you might say eugenic, biologically deterministic patterns. So I think there's more attention to that, but maybe what I'd say is that there's probably more of an uptick in public health and the social sciences than there is in medicine per se, but but at least there's sort of some attention that's been raised recently to that. To the race science. Somebody in the chat described it as.
I think you definitely touched on this, but I really would like to bring this up because also he's a friend of the show, and I know you actually has been a student, because one of the early things that we saw in COVID-19, as you mentioned, was how the coronavirus illness and death was being categorized in racial terms. I remember, and I know many of us do, that when Adolph Reed was trying, who was a friend of the show, was literally being boycotted for questioning the way in which COVID illness was being racialized. Can you explain to our audience the premise of Adolph's concerns and how your research might place those debates in proper context?
Yeah, no, absolutely. I think that, kind of what I've said is in line with what Adolf Reed has said about kind of the problematic repetition of these kind of statistics. I can't share a screen, but if I could, I would have shown you this study that was done by some researchers at Harvard where they were looking.
You can share a screen.
Oh,
on the bottom, you should see a picture.
Had I known that, I would have had it. Had I known that, I would have had it ready to go. Let me just try to try to describe it. Maybe I can find it if we pause for a second. But this is just what I want to describe. These Harvard researchers looked at COVID death rates for each racial and ethnic category by educational status. Do you follow what I'm saying? So within each group, they're looking at not just the mortality rate, but they're breaking each group down by educational status. And guess what? The bar graphs look the same for each. I'm not saying that there's not disparities, between racial and ethnic categories. What I'm saying is that what's most profound about their finding is the pervasive class pattern to it. And we know why, right? We know what increased risk of exposure and, sort of succumbing to COVID-19, right? It's frontline workers, it's the nature of your housing, public transportation that you have to use, your ability to social distance, your ability to work remotely, and so forth. And so for all groups, Native and Pacific Islanders, Latino, Latinx populations, Black populations, white populations, you see those mortality statistics stratified by social class. And that's the problem. I mean, we have a tendency in the United States to when we're speaking of disparity and inequity, we have a tendency to emphasize, as we said before, kind of these racial and ethnic categories. And I wouldn't say that's not important, but it can then obfuscate these deeper patterns, right, that are about, the nature of economic inequality and how public health hazards are distributed, in that way.
One of the things I want to ask you, Djene, about this rise of disparities and disparitarian thinking that really starts to gain popularity in the early aughts, I would say actually around the second term of the Obama presidency. We start to see this really mass inundation of studies, scholarship, and research that are figuring around racial disparities, particularly about racial disparities, around racial disparities around wealth, income, quality of life, et cetera, so forth. None of them talk about the internal class dynamics of these various groups, but there is this massive bombardment in these data analyses around racial disparities, and starting around like 2015 and 16. Now, I'm not asking you to buy into a conspiracy theory because I know you're not, and I don't claim to be. Do you think there is a correlation between the rise of disparities-based research? Most of these studies were coming out of Ivy League or highly elite institution academic programs, nonprofit NGO type organizations like the Brookings Institute, very free market neoliberal think tanks. None of them were, proletariat or grassroots organizations. Do you think that it's possible that there is a correlation between the rise of this focus on disparitarian or disparities discourse and research and the increased popularity of social democracy as a political option in the American body politic? Or do you think I'm completely off the mark in making a correlation? I didn't say causation, correlation between the two.
Yeah, I don't know if I don't know if this was really intentional, but this is what I will say. I will say that there's been an explosion in research on racism and health, on health disparities, on health equity. You know, that if you look at the number of published papers over time, and again, I don't know if I have time in this to find the slide and show the screen, you know, there's really been an exponential increase in the volume of papers that you see published where, you know, scholars have been able to show the linkage between residential segregation, subjective experience of racism, you know, various forms of inequality and health outcomes. So this has been a kind of growing trend in the research. Yet interestingly, you know, that none of this has really moved the needle, you know, in terms of any of these disparities and statistics. And in fact, as I mentioned, you know, we could argue that whites in the United States, likely due to declining economic fortunes under neoliberalism, you know, due to free trade agreements like NAFTA, GATT, and the loss of manufacturing, you know, the trend in health is almost inverse to the you know, the volume of publication that's going on. That's one thing that I'd say. The other thing that I'd say is that, you know, the United States is a little bit different. You do find that in most other wealthy nations, there is a willingness to at least investigate, you know, class in terms of these racial disparities or health inequities, much more so than you find in the U.S. context, right? So in the UK and New Zealand, you know, in much of Europe, I mean, I'm not suggesting that it's utopian, but you do find more willingness to take up these issues, you know, in terms of a class dimension than you see in the United States, you know. And I guess maybe to your point where I'd say some of the problem lies is it's the class dynamic within Black politics, within, you know, Latinx politics. It's the class dimension within that also suppresses a focus on some of these issues.
That's fascinating. So what you're saying is that the class makeup of the people, even people of color, who would be doing or be sanctioned to do this research would reify a kind of academic focus on race divorced from a class analysis? Is that what you...
Yeah, I would definitely say that in a way, you know, researchers are following contemporary trends in U.S. politics. Researchers are embedded in the same kind of matrices of thought, you know, historical context that we're in. And we're in a neoliberal one, right? And in a neoliberal one, you can emphasize racial, ethnic, and these sorts of disparities, but, you know, generally there's silence over on substantive issues around economic inequality. And I think it's more pronounced, you know, in the United States than in my experience and observation. I've had an opportunity to travel a little bit and see what it looks like, you know, outside the United States. And that's one of the things that has really struck me.
Wow, well, I really appreciate your input as an academic and scholar who is in the trenches doing this research and seeing the type of stuff that your coworkers, your cohorts, or your co-professionals are doing in terms of this kind of research. Do you, and on a not so much on a personal note, do you find that the people who tend to be the most hostile to the type of scholarship that you do, within the line of the Barbara Fields, the Adolph Reeds, the Cedric Johnsons, the Torrey Reeds, the Kenneth Warrens, do you find that it's actually people within the liberal Black and brown institutional mechanisms that are more hostile to these class-based analyses? Or do you find that it is mainstream, kind of more white academics? Where do you find the greatest pushback?
Well, I think, I just think that right now, you know, a lot of people believe that, you know, if you're talking about equity, it sort of must be about white supremacy. It must be, if you're not rooting your critical analyses in that kind of position, then you're not taking these issues seriously, and I think that it is definitely pervasive in the academy. But you know what? It's reflective of the political moment that we're in. We're at a time when union density, for example, is significantly lower than it was 30, 40 years ago, right? We're in a time when, we've experienced neoliberalism and kind of redistribution upwards. So I guess what I would say is that the tendencies that I see in academics are very congruent to, kind of what's going on, in contemporary U.S. politics. And I think that that's why, as I said before, it's kind of interesting that when I'm engaged with this group in Springfield, MoCA, again, they have a very clear analysis. I feel like it's when I get, among certain academic audiences that for some reason, I don't completely understand. It's a little bit harder to connect the dots. I did find this slide that I'd like to show if I could. Could I show the slide?
Yeah. You can share a screen. Yeah. Okay. I did want to say, does it kind of boil down to about funding for your research? Not boil down, but is that a factor?
Yeah, and I think that it, as I was saying, that I have noticed that outside the United States, in the UK and Scotland and New Zealand, countries like that have a tradition of health equities research, the parameters of the kind of questions that you can ask can be much more provocative and I'd say even radical. Work looking at, for example, the collapse of communism and death rates among Russian men and Eastern European men. I've seen funding in the European context for those kind of questions. In the United States, as you can imagine, the National Institutes of Health tends to emphasize a much more biomedical approach. And, they stay clear of questions that really deal with power, and economic inequality, for sure. Let me show this
please.
One slide. Yep. Is that okay?
Yeah, sure. Please. We're waiting.
Okay.
I wish I had a drum roll. Oh, I hear it.
Wait, what?
Damn.
Wait. What do I do? Oh, there we go. Okay.
Whatever you did, you just opened the matrix. Okay,
right,
now I see it.
Can you all see this?
Yeah.
Yes.
Okay, so what we're looking at, this is a graph that captures excess Black deaths among people under 55 years of age, and we're looking at before and after the Reagan and Bush administrations. Now, let me define what I mean. An excess Black death is a death that wouldn't have occurred if the death rate was the same as it was for whites once you factor in sex and age. To use the statistical jargon, you'd say when you control for sex and age. Why would you control for sex and age? You want to make sure that if there's a higher death rate, it's not due to the fact that there's a different age distribution among Black people compared to whites. You want to make sure that there's not a different sex distribution, males to females. So when you factor that in, these dots represent in tens of thousands the number of excess deaths that occurred that would not have if the death rate had been the same. Now, what you notice is coming out of the 1960s until Ronald Reagan, there's a dramatic drop in Black excess death rates. This means that there's a convergence in mortality. And my collaborator, we're working on a book project, Javier Rodriguez and I estimate, that's what this dotted line is, we project that had we stayed on the trend that was established in the 1960s, we would have eliminated the racial disparity in the early 2000s, right? But of course, Reagan is elected in 1980, and you see a sharp upward trend in terms of Black excess mortality, and then you see it fall under Clinton, okay? Now, these are clearly distinct periods of U.S. political economy. This is the period of the civil rights movement. It's the period of Great Society, war on poverty. This is when we enacted Medicare and Medicaid, elementary and secondary education, community action, the bundle of policies that characterize that period. Mm-hmm. And then this is the period of the inception of neoliberalism, right, and the Reagan Revolution. Now, when we looked at this at first, it was a bit puzzling because Clinton is elected in 1992, and and everyone here knows that the Clinton administration was advancing, punitive criminal justice and welfare reform measures. So why would Black people gain relative to whites, right, in terms of mortality rates? That's what this means. And what our research is suggesting, it's not that government intervention was good for Black people, but it's rather that government intervention was beginning to have a deleterious impact on working class whites, which I alluded to before. So the deaths of despair, somebody in the chat mentioned, this is work by Angus Deaton and Ann Chase at Princeton. They were the first researchers to kind of notice this pattern of high death rates among middle-aged whites. That's a phenomenon that is established by macroeconomic policy in the 1990s. So when you look at this, I'm going to come out of it if I can figure out how. So when you look at this, you have the immediate answer as to why this has nothing to do with genes. Like there's no way that evolution is happening at a pace and with a kind of specificity that would explain that. What explains this is political economy, right, and the various social and economic policies that correspond to these different periods in question. So how do I get out of this now? Yeah.
You're good.
I went ahead and closed it.
You know what's really fascinating and profound in what Djene is saying here, right? Basically, the policies of the Great Society in the late 60s and all of those government programs that we're always trained to believe were worthless, that Thomas Sowell always tell us didn't have any value, basically are improving the quality of life of Black people who literally within a decade before were sharecroppers and domestic workers.
Well, they don't have access to health care.
Right. That because of those Great Society programs and the expansion of Medicaid, Medicare, and all those programs, their mortality or surplus mortality is getting better relative to whites. In other words, they are becoming on par with whites up until the period of hardcore neoliberalism starting with Reagan, and they get worse, horrible, because we know that those programs are gutted, et cetera, et cetera. So the Black mortality goes up, skyrockets, right? And so that's logical. But what is the deepest thing that these studies show is that the reason why under Clinton, the Black-white mortality starts to come close together isn't because Clinton is doing good policy for anyone. It's that his policies are so bad for everyone that whites and Blacks are starting to die at the same rate, i.e. NAFTA, GATT, and everything else.
I mean, the welfare cut wasn't just to colored folks.
That's incredible.
Well, I do want to address this super chat before we go. Thank you very much, JB, for the super chat. Before the show ends, can the guest, Dr. Dean Robinson, speak to women's health and, in particular, Black women in the context of this amazing conversation about the reality of disparities? TIR is the best. Thank you. Thank you very much, JB.
Yeah, good question. So it was actually Black women that enjoyed the most traumatic improvements as the result of changes brought on by the civil rights movement and social policies of that era. So of the populations that we look at, and in public health research, usually when you're looking at heart disease or you're looking at diabetes, really any health statistic, you stratify, as they say, by sex. So you look at males, you look at females, and it's definitely the case that Black women saw the greatest gains. And if you think back to the comment that I made earlier, health is a function of your material and your psychosocial experience, right? So, mid 1960s to 1980 for blacks in the United States, and by the way, for socioeconomically disadvantaged groups in general, was a period of improving material circumstances and also greater feelings of empowerment. Remember, I said that there's evidence that suggests that the feeling of subordination, like on a psychological dimension, is also implicated in the stress response. And so there's no question that, coming out of that period, when you look at it, it would make total sense. Black women was the population in the United States that saw the most significant gains. Let me just mention a piece of research that I just published with Jessica Perlman at UMass Sociology. We looked at what we were wondering is whether or not we could show, based on this sort of more class or socioeconomic analysis, whether we could show whether states' investment in anti-poverty programs, right, the absolute money that is spent on housing, on welfare, on earned income tax credit, minimum wages, the bundle of policies that provide some degree of economic insecurity. If socioeconomic or class status is what drives health statistics, would states that did more in terms of anti-poverty improve pregnancy outcomes for women? And we had data for white women and black women. So we looked at about 60 million, very statistical kind of analysis, 60 million births over a period of 1997 to 2017. And we looked at it by educational status. So we were looking at race, black and white, as well as educational status. And we found that states that provided more in the way of an earned income tax credit, greater generosity of the earned income tax credit was good for black mothers on measures of preterm birth and low birth weight, right? Preterm birth and low birth weight are indicators that put individuals at risk for infant mortality and for all sorts of health problems at later stages in life. So we found that the earned income tax credit, right, greater generosity had an impact on the outcomes of black mothers, and that impact was greater as you went down in terms of socioeconomic status. So it was a great illustration of what I think is the right way to try to conduct an intersectional analysis, right? We're looking at race, gender, and class, and you're able to show the way in which government policy can be implicated in health outcomes that can, to a positive effect. We don't have the data yet to look at it, but we think that by virtue of the relief and increase in subsidy and credits to families that is estimated to have reduced child poverty by 50%. We think, we haven't done the analysis yet, that is going to have even more dramatic improvement in these kind of health outcomes for black women. So that's what I'd say.
Amazing.
So, that's just sort of touching on it. There's more to say, in terms of women and health, but I just wanted to share that.
Well, thank you so much for spending some time with us, Dean. See, that hour just flew right by.
Dean, listen, brother, are you down to spend a little time in the champagne room, or do you have to tend to other obligations?
Absolutely, I can spend a little time. Yeah.
We do want to ask you a couple Black nationalism questions before we officially let you go. When we go to the champagne room, there's going to be
Jason got me psyched. Jason, you don't have to threaten me with a good time.
Thank you very much, Dean. Pascal, thank you so much, chat. Thank you guys for the super chats. That does keep this show going. Also, don't forget, tomorrow at 6 p.m. Pacific Standard Time. We will be airing the new video essay. Don't have a title for it yet. I'm in between titles. I haven't decided which one I'm going with. But if you are a patron, the link is already up to the champagne room, and we will see you guys there shortly. As I do have to finish up this video essay tonight. So thank you guys, and we are out.